Hi, I'm Duane Pinto here at SCAI 2015 here in San Diego. I'm joined by my colleague, Dr. Charles Laham from Manitoba, Wisconsin, who is here to talk with us about a novel strategy to deal with a very common problem for the interventional cardiologist when you need to interrupt DAPT for a surgical procedure. So welcome, first of all, thanks for joining us.
Thanks for the opportunity.
Yeah, and so tell me a little bit more about your study.
Well, the study was originally meant as a clinical survival. You know, we were getting 10, 15 calls a week with a very high volume center at the time, what to do with the antiplatelet agents in people that have had drug-eluting stents. 2003, I was at a conference. One of the major centers said, well, maybe we use Cilostazol in that setting. When we heard that, we said, well, maybe we can try that. So we started, in 4 or 5 patients and found that it was effective, and then started applying that to a bigger population. Initially, the drug-eluting stents were approved for dual antiplatelet therapy 3 to 6 months. That was Cilostazol, sirolimus, and eventually was extended to 6 months for Taxus. But by 2007, that was extended to a year. And then, because of late events with stent thrombosis, that eventually people were using it indefinitely. So we have bridging experience with all of those levels. And when 2008, when things were extended, especially in the first generation stents to indefinitely, we actually bridged people out to 5 years. We just said, was it safe? We never knew if it was safe or not. So what we ended up doing is, initially it was unavoidable surgeries, and then we eventually became more sort of moderate need, and then eventually to elective surgeries beyond a year. So we were able to examine 180 or so patients that had bridging with all different indications, including high bleeding risk. We've had 50 patient experience or more with bridging spine procedures where they need to epidural or have back surgery. Those are obviously the highest risk ones where the surgeons don't want any chance of bleeding. So in those settings, we were able to find a little more of a modification to what we considered our standard regimen. The standard regimen consists of, and the other point was, and we'll talk about the standard regimen in a second, was that the surgeons were very bleeding adverse in this area where we were working. They didn't want aspirin or Plavix involved, so both DAPT were stopped. Mm-hmm. And 95% of the patients had Taxus stents because that was the population
used,
at the time. So the study that we're reporting is exclusively with the Taxus stent. We have bridging experience with non-medicated stents. We have some in the newer generations, some even in bridging GI bleeds, but those are beyond the limits of our current study. What we did was we stopped the DAPT therapy, which at the time was aspirin and Clopidogrel almost exclusively, 8 days after the dose on the 8th day preoperatively. Then we used Cilostazol 100 milligrams twice daily, and depending on the bleeding risk, when we would stop it. For the high bleeding risk patients, we stopped that 54 to 60 hours before the surgery and resumed DAPT preferably at 24 to 48 hours. That was the recommendation. Now,
restarting aspirin Clopidogrel.
Both of them restarted at, for sure, ideally at 24, but for 48 hours.
And with the loading dose or just the maintenance dose?
We actually gave 2 tablets of aspirin and Clopidogrel at the time of each, and then went on 1 tablet daily thereafter. For the more low to moderate risk bleeding patients, we actually continued the 100 milligram twice daily until 24 to 30 hours before the surgery and resumed DAPT either 12 to 24 hours. Now, in the patients that followed that regimen, some patients had some of the obvious side effects that you get with Cilostazol, where they had upset stomach and headaches and palpitations. In those patients where we felt that there was enough of side effects that we would reduce the dose to 50 milligrams twice daily. Mm-hmm. And those ones did fine. Some of the patients that were intolerant called the surgeon instead of calling us. And the surgeon says, well, you shouldn't be on blood thinners. They went ahead and stopped it. Well, interestingly enough, those were the same surgeons that didn't restart DAPT at by 72 hours. And some of those patients, were 5-7 days out without DAPT after the surgery. So that's a really, interesting sort of control group, if you will, of unplanned therapy. Mm-hmm. So with following this protocol, 171 patients were bridged with the full protocol between 2 weeks and 60 months after a Taxol stent. In these patients, everyone that followed that ideal recipe, got back on the DAPT at the required time, none of those patients had any adverse events. We followed those adverse events for 30 days. We also looked for bleeding as a second endpoint, and there really was no clinical significant bleeding where additional transfusions were needed or clinically significant events.
So amongst the 170 plus, no acute stent thrombosis.
No acute stent thrombosis.
And no bleeding events.
And no real bleeding other than nuisance bleeding. And none that really required modifying. Now, of course, it was slightly individualized by the surgeon, but we considered appropriate therapy if they took more than 500 milligrams preoperatively. A few of the patients had a shortened bridge period because there were more urgent surgeries. So if they were doing a spine surgery, for example, or a high bleeding risk surgery, they would take 50 twice a day. Well, you're not going to get more than 10 doses in. So we considered around 500 the cutoff.
And what proportion of the patients were within, say, a 4-6 week time period from the initial index stent implantation, where we wonder whether that's a higher risk population to go for surgery?
We've found, the historical controls, and I think that this comes out of a study or report by Antonio Colombo and Sam Musa, where they wrote an editorial about it. We know that the background risk if you stop dual antiplatelet therapy in the first 30 days is almost 25% event rate. And in the Premier data, there was approximately a 10% event rate at a year. And those were probably first generation stents as well. If you stop either of the DAPT, and then beyond that, we've seen with the Taxus follow-up that the event rate is approximately 7% out to 30 months. So we thought that this was still valuable data that we had, even though we had collected most of this up till 2008, that we still had bridging up to 2012 experience with the Paclitaxel. Now, with these patients, we mentioned that they were off both antiplatelet agents, but we also don't know what the background risk is when they are off for surgery, because surgery is actually a theoretically higher hypercoagulable state versus someone just stopping antiplatelet therapy because they ran out of money or that they thought it was time.
Sure.
So it may be even theoretically a higher risk group. Occasionally, patients that had events, there were 12 patients that either were told to stop the blood thinner by the surgeons, and of that 12, 8 or so did not take more than 200 or 300 milligrams of Cilostazol preoperatively, and 8 out of that 12 as well did not resume DAPT after the procedures. So 8 out of the 12 actually did not have events, 4 did. Then where are the events? One was at eight months. That was when the recommendation was still six months of therapy with a Paclitaxel stent. And the subsequent events in the other 3 patients, one was at 13 months, one was at 28 months, and another one at 40 months. So this is 3 out of the 4
events. They
events.
were off-all therapy.
Off-all therapy in Paclitaxel stents beyond a year. So if you look at the groups, we had 29 or so patients in the first.
And when was the time between the surgery and these events?
So after the surgery, it was almost exclusively after the surgery. A few of them were at, one event was at 5 days, and 2 events were at 7 days.
Yeah, so very short after the
So
surgery.
very short after the
very
surgery.
Far out from the
Paclitaxel.
And before DAPT, even a time where we might think that you might not need to be on dual antiplatelet therapy.
Well, the issue was that in this study, short of emergency surgeries, that we followed every guidelines, unless it was an urgent surgery. Every guideline in place at that time, 2005, 2006, again, extending out to a year, extending out, we didn't really know, indefinitely. Yeah. But now we're seeing the data, several years later, look, in the long-term follow-up of Paclitaxel stents, that maybe 30 months, I've seen Paclitaxel drug stent events at 5 and 6 years out. I mark one of the ones sort of just like the IDEA control group. This guy is 7 years after Taxus, and he had a major stent thrombosis. Now we don't know if that's neovascular, neointimal, neoatherosclerosis, or whether that's really some kind of inflammatory thing from the stent. And I really don't think that, a person taking 100 or 200 milligrams of Cilostazol and having an event 10 days out, really is related to this loss. So we know the background is that the patients that aren't bridged really have big events.
Yeah.
So I think that, that this is feasible, but it requires a lot of interaction between you and the patient, you and the surgeon. You got to make sure that they know for sure that, look, this is not fooling around. And I just said that I make them sign a paper. This was not a study at the time. I made them sign a paper. Look, you're going to agree to do this because there's a risk that you're not going to have a good outcome if you stop this thing. And I don't want you to not restart it. But occasionally, people listen to what the doctors and surgeon says. I don't want any bleeding. So you really have to do this.
Shows the importance of communication
and
everybody being part of the team and engaging
and following,
the patients. Yeah.
And making sure that the patients are invested in it. They report back to you. You really have to have good support from your partners too. You're away for a week. Some of those non-compliant or protocol violations, if you will, even though it wasn't an established protocol at the time, were because you were off for that week and the partner was covering. They didn't understand. Not everyone or their surgeons didn't understand, or the patients really. So education and communication. But I mean, it's been very tricky. We know that Lovenox is not been effective or release of bleeding. We know the GP2B3 inhibitors have some of the same problems. This was an outpatient bridging for the most part. This was potentially, there might be definitely some financial, benefits to all of this because if people can take this at home.
Yeah.
And in this really high-risk patient setting, off of aspirin, Paclitaxel stents, which we know, and the higher chances of having surgeries is really a high-risk group. So it's compelling to think that it would work in other settings. We mentioned that we've had experience in other settings in smaller numbers, but we really think that there's potential for a randomized study or a more controlled study where the nurses are calling the patient every day, are you taking this?
Yeah.
See, we didn't necessarily at the time have a research plan, so we didn't necessarily add up how many tablets they took relative to what they should have took. We're almost sure that the events that occurred because the patient either didn't pick up the medication or somebody had told them not to take it at some point.
Yeah.
So.
And you wonder if having platelet function testing might inform dosing of the medications or not, et cetera, and if there might be some sort of effect based on what degree of platelet inhibition there is.
I think that would be the next study should conclude that. Are we really achieving what we think we are achieving?
Yeah.
We know that Cilostazol is kind of an indirect aggregate and platelet inhibitor. But I mean, the data in the Asian population is really compelling in terms of, wow, some of these patients are not PG2, P2Y212 inhibitor interactive, where they've got high on-target platelet reactivity when really you don't want that.
So Dr. Laham, tell me the take-home points for our audience. Obviously still a work in progress, not the standard of care, but what's the take-home points? I
think the take-home points is in a pinch, in a controlled environment, Cilostazol has been seen to be effective in a high-risk population, and since the current populations don't necessarily stop aspirin, it may potentially have even better benefit in the current generation of stents that have lower risk and that don't stop aspirin, and that maybe that the surgeons are a little bit less risk averse for bleeding. We're learning more and more about the drug-eluting stents not being safe. And then certainly looking at bare metal stents and clinical applications in patients that you just want to put some of the antiplatelet agents back when they're bleeding, or that you're worried that something is headed down. So I really think that there's a potential for more further study, controlled, tablet counted, nurse involved, a lot of input from the patients, and really testing in a modern environment.
So last question, you have a proximal LAD, second generation DES, and you're having your knee scoped, and the surgeon doesn't want to have you on anything. Get your knee scoped or go on Cilostazol?
Well, it depends. If you're a high-performance athlete and your life is dependent on that, they're going to really want to push for that. I think
I doubt many high-performance athletes have proximal LAD stents.
Well, what we know now is that, that if you can delay the surgery, preferably. But if you're in a pinch, you need a gallbladder taken out or something, and you're going to lose the function of the knee permanently if you don't do something. I would feel comfortable, bridging with, and I probably would continue the aspirin, and just twist the arm. And if they're and I might actually, not stop it as far in advance and insist that they go back on antiplatelet agents, dual antiplatelet agents. So I think that those are feasible. Some of those timelines with platelet reactivity and insight from more controlled, bleeding tests as to what, is there going to be a high bleeding risk with the surgery. I think that those things, if they're tested, you can actually tailor the dose to when it's time. And we know that there are interactions with Cilostazol, for example, with proton pump inhibitors, with some other medications such as diltiazem, where theoretically that maybe we could have or should have reduced the dose and maybe would have had a little more tolerance from the patient. So there's opportunities for more study.
And I think your point too of having open communication with the surgeons and the patient, I find actually when I talk to the surgeons, they're not so unreasonable when I explain the consequences of stent thrombosis for the patient. And many times they can modify whether they leave a drain in or not or things like that, and often understand what we're all dealing with here. But obviously cutting edge stuff
Well, but the issue is, and I want to emphasize this for sure, this is off-label. This is definitely off-label. It was not necessarily approved for this indication, but I mean, there's compelling evidence from Asia that this may be sort of your backup second line or third line thought, and that this was not a controlled study. It was a retrospective study. Really, that it's more hypothesis generating and attractive. That at least there's some data now, because the data has been pretty sketchy in the literature. I know last year that SCAI had a whole editorial on what the different centers were doing, and quite frankly, there was no consensus. So I thought as soon as I saw that article, I said it's time to start putting this back together and get it going.
Yeah, well, thank you for doing that, and thank you for giving us a lot to think about as well. And thank you for joining us, Dr. Laham. Thank you for joining us here too at SCAI 2015.
Thanks for your attention.